Okay, so I'm Laura. I'm one of the fifth year medical students at Green Templeton, and today we'll be covering somatosensory pathways and pain also. So the way we'll go about it is split it into 5 bits, the talk. So first gonna go over the receptors, then the dorsal column system, anterolateral system, a couple of spinal cord lesions where is quite common for MCQ questions, and then a bit on the cortical representation of the somatosensory information. And so I'll be mainly focusing on the part A content, but I also have some hidden slides that have some part B, or like now I know you guys have MCQ paper followed by an essay question. So essentially the essay content, it will be on the hidden slides that you will get after the session as you complete the feedback. As then it just means that we focus on the high yield stuff first, and then if you want to write an essay on this maybe in your exams, then you can read about it from the notes. Okay, so intro to somatosensation. Main point is to perceive and interpret physical sense that goes from noise perception, that is interpreted as pain in the brain, temperature, proprioception, that is the joint position that you can have even with closing your eyes, and then crude touch, fine touch. And all of these are transduced by different receptors. The receptors, they have different modalities, like we just said about temperature, nociception, etc. And sensitivity, that means at which threshold they will become activated. And then also they have different adaptation. Adaptation means it might have come across in the Pacinian corpuscle that it's a receptor which mainly cares for vibration. So as soon as you press the receptor, say you sit down, the signal, if you don't add any change to it, then it will stop signaling. So that means to adapt, even it has the same input, it decreases in the signaling. And then finally, we also have to think about which fibers these receptors are connected to, because that will matter about the speed at which they transmit. Okay, so yeah, we said about the different modalities. And so, for example, in the skin, we've got two main different things. So the small and the large receptor size field. That means the smaller ones are usually on the surface of the skin, and these are the Meissner's and Merkel's disc. So the main thing to remember between both of them is that Meissner's is rapidly adapting. So that means because we said it will stop signaling, it's more to do with fine touch. And the way I remember that is Meissner sounds like a smooth word to me, whereas Merkel's sounds more like a rough word. That sounds like more like a crude touch, but you guys can remember it how you prefer. And then for more of the large receptive size fields are Pacinian corpuscles we mentioned. And these are, like we said, rapidly adapting. So say as soon as you sit down, you first felt that you sat down, but then it doesn't keep signaling. And so it's more adapted for vibration, whereas Ruffini endings are more for the stretching of the skin. So my first MCQ question is a test to see before we cover that content. So hopefully you guys can still, you probably can't see my screen right now, but hopefully you can see it now and you can join the quiz. So if you can see my screen, you got the QR code there and the number there if you prefer. Great. So first question. Which type of nerve fibers convey information from mechanoreceptors in the skin to the brain? Good. So all of you guys got it right. And now we'll quickly go over that. Yeah, so as you said, the mechanoreceptors are A beta fibers. And the thing with this table is definitely high yield for the multiple choice. But one thing that might be a bit tricky is sometimes the numbers they use in the MCQs are slightly different. So the thing to remember is, so A alpha is the quickest because they are thick in diameter and they've got myelin. So with myelin, you would have a faster conduction. And these are A alpha for proprioceptors from muscle spindles and the Golgi tendon organs. So second, like you guys got it absolutely right, you've got A beta, and which is myelinated again, and it will be slower, but not as slow as the A delta and C fibers, which both of these are pain. But they are different types of pain or flavors of pain, in that A delta is usually for the more sharp and localizing pain that you get immediately, followed by the C fibers, which come on a bit later, but are more long lasting because C fibers don't have any adaptation. And that's what we just spoken about here. But the question might come up is neurotransmitters. A delta fibers are usually glutamate, and then the C fibers, glutamate and substance P. So with nociceptors, these have a higher threshold usually than the mechanoreceptors, and their receptive field is much larger. So it's not that you can feel exactly which spot the pain is from, but it's like from the general area. Right. And the other two things to remember is that with nociceptors, you can have hyperalgesia and allodynia. In hyperalgesia, there's two main mechanisms. One is the peripheral one, which could be from the chemicals that are released from the tissue injury. And for example, like prostaglandin, bradykinin, hydrogen ions, etc. But there's another one that is a central hyperalgesia that I have written a bit more in the notes from the slides if you want to read about, but it's linked with neuropathic and chronic pain. So overall, we said nociception is the sense that is detected like from the body, but then pain is the interpretation of that nociception in the brain. And the important thing is that it's not a one-to-one relationship, so it can be modulated at several steps. We mentioned a couple from increasing pain in terms of hyperalgesia, but there's also some more that we can mention later in the lecture about descending input that can either increase or decrease the pain. And essentially the important thing about it is to learn from experience, and because then you want to get away from that pain. And in the and a clinical example is if the sodium channels that are important for detecting pain with nociception are not working, like in a sodium channelopathy of NaV 1.2, then people can get really injured and even break bones and not realize, and then that can be long-term very harmful for them. So another clinical bit. So we said that the C fibers and A delta fibers are the smaller ones, and that's important in local anesthesia where the smaller fibers are more affected by the anesthesia compared to the larger ones. So that means, for example, in surgery, if patient is awake, then they might say you might feel some pushing and pulling, but you shouldn't feel any pain. And if they feel pain, then you can give some more local anesthetic. And then another point to make, maybe a bit more small here, is about if you're studying about what is the cause of the neuropathy. If you've lost axons in neurophysiology, you will have a smaller amplitude. That means like basically when you do neurophysiology, you're measuring the nerve activity, then the spikes will be smaller. And if it's demyelinated, then it will slow the velocity. As we said, myelin increases the velocity. Right, so we're on to the next question, hopefully. And I hope you can still see my screen. Right, so which neurotransmitters do neurons that convey nociception information use? I think we got, yeah, well done, guys. So we're done with somatosensory receptors. So now we're moving up the spinal cord and we're going to look into the dorsal columns and the anterolateral system. This is anatomy in the end, so it is just kind of a, you have to learn it like step by step. But once you've gone through it enough times, then you won't forget it and it will be an easy answer in the MCQ. Right, so we said we have the dorsal column and the anterolateral system. So dorsal column is mainly touch, vibration, proprioception. So we were saying about mechanoreception, and the anterolateral system is for noxious and temperature, but also some crude touch comes in there. So if you ask me here, what does that mean in terms of the spined neuroanatomy? So here we have a cross section, and a way that I remember which is the front and which is the back is that you can see this is like a Pac-Man. So this is the mouth. So, and the mouth is at the front. So this is the anterior part of the spinal cord, and this is the posterior or the dorsal part of the spinal cord. So here we can see this is the dorsal columns in the back because they're, as we said, this is the face of your Pac-Man. And this one, the anterolateral, as the name says, is anterior and lateral. So first, in the dorsal column system, the neurons go straight up the dorsal columns, and they don't have any synapse in the spinal cord until they get all the way to the nucleuses that are in the brainstem. So important thing about this is that you have the leg side of the dorsal columns and the arm side of the dorsal columns. So if we go through it, so the leg part is the fasciculus gracilis, and it travels all the way up to the gracili nucleus in the medulla. So if we had the here, the arm part is the B, so it's the the cuneatus fasciculus, and then the A is the gracilis fasciculus. So as we said, because if you think about it, in terms of this one, it's like the legs have to go all the way down with the gracilis fasciculus, whereas the arms only have to go half of the way. That's why they're like on the outside of the spinal cord bit. So I think I have done a bit of jiggling backwards and forwards with the slides, so I'll make sure to repeat this again. So yeah, so we had then we went from the gracilis fasciculus and the cuneatus fasciculus up the dorsal column system, and then you have the synapse at the nucleus cuneatus and the nucleus gracilis in the medulla. And from these, then they go all the way up to the thalamus. And the dorsal column system changes its name then, just to be confusing, I think, because basically what a medial lemniscus means is just another bundle of nerves that it just changes its name because the information goes through the brainstem. So essentially, we had the dorsal columns through a spinal cord, and then we changed the name to medial lemniscus just because we're in the brainstem. And then once it synapses in the thalamus, then it goes to the somatosensory cortex. But the important name to remember in where it synapses in the thalamus is that it's the ventroposterior lateral nucleus. Okay? And then, as you said, finally, the third order neurons go to the somatosensory cortex, and they do that through the posterior limb of the internal capsule. Okay, quick recap because we had a backwards and forward with the slides. We started in the body, in the skin, say, and then we, with the receptor, went to the dorsal root ganglion, which is the body of the first order neuron, then ascended ipsilaterally and then met the gracilis nucleus and the cuneatus nucleus, depending if gracilis was the leg one, because how I remember it is graceful legs, and then second, the cuneatus is the armed one because it's just the other one basically, and then it quickly crosses over after that in the midbrain as a second order neuron, which ascends as the medial lemniscus, which is just another name for a bunch of nerves going up the brainstem, and then meets the thalamus. And the important part to remember is in the ventral posterior lateral nucleus of the thalamus before going to the somatosensory cortex as the third order neurons. Okay, so that was a lot. So let's see if we can get the next question then. So, where are the cell bodies of the neurons that convey somatosensory information from the skin to the CNS? Let's have a look. Okay, almost there for everybody. So we said, is it at the dorsal root ganglion? So that's how we had the mechanoreceptor. The first order neuron goes all the way up to the brainstem to meet the two nuclei that we mentioned. But the cell body of the first order neuron is at the dorsal root ganglion. Great. Because we're here already, let's try the next question. So which thalamic nucleus is associated with the somatosensory pathway? And we've got 3 people answering. So almost right for everybody, but so let's recap where that happened. So the medial lemniscus, so lemniscus is the bunch of nerves that goes from the brainstem to the thalamus. So the second part of you had the dorsal columns and then followed by the medial lemniscus. So the actual nucleus in the thalamus is called ventral posterior lateral. So that's probably where the mistake went, but this is definitely related to the somatosensory pathway. It's just not the thalamic nucleus, it's the brainstem pathway. And these other two, just for fun, is almost to do with the eyes, vision, and medial geniculate nucleus is with hearing in the thalamus. Okay, so let's keep going ahead. We've covered some of the sensory receptors and dorsal column system. Main thing to remember, it was ascending ipsilaterally up the spinal cord, and then at the brainstem it decussates, and then it keeps going up to the thalamus and then the cortex. So now anterolateral system is different. And first, anterolateral system, before we go over the anatomy from receptor to cortex, let's think about what it composes the anterolateral system. The main thing we've been talking about is the spinothalamic path, that is for pain. And the main target, similar to or the same as the somatosensory, so the other part of somatosensation, sorry, is in the ventral posterior lateral part of the nucleus of the thalamus. But there's two other things to consider in the anterolateral system, that is the spinal-reticular and spinomesencephalic. Main difference, spinal-reticular is it's the kind of the alert system. So you can imagine if you're in pain, you then have to be more awake, and it has essentially goes up the spinal cord and instead synapses with the reticular activating system in the brainstem. So you hear about the reticular formation, and this has different connections to hypothalamus, thalamus, and cortex. Makes sense. Hypothalamus is regulating about energy, about behavior, in terms of like how to adapt to what's coming up. But then the thalamus as the relay station still makes sense because it will go to other parts of the brain. And then some of it goes to the cortex. That means to be more awake, because like you would have in your sleep lectures, you have the relationship between cortex and thalamus that is more complicated, like neuroscience, about that modulates wakefulness and consciousness. Okay, and third, spinomesencephalic instead is a descending part of the anterolateral system, and the main part of it is that it's for pain modulation. And the key output from it is the periaqueductal gray in the midbrain. Okay, so now let's go through the neuroanatomy of the anterolateral system. Okay, so first, or the neurons. We still have our body in the dorsal root ganglion, but instead of going all the way laterally, we do something else. We immediately synapse at the dorsal horn, and then we go up or one or two vertebral levels through the Lissauer's tract to amplify the nociceptive signal. And then at this synapse, we have the second order neuron, which goes all the way up to the thalamus. At the synapse, we have a synapsing in the dorsal horn, which is the split into different numbers. And I wouldn't go over the top to learn exactly which was which, but the two important terms to learn about is the substantia gelatinosa, which is the site of pain modulation, and the nucleus proprius, which is about mechanical and temperature sensation to the brain. Okay, so we had our first order neuron that immediately synapses in the dorsal horn and then immediately decussates. That means crosses over to the other side of the spinal cord and then ascends contralaterally to the thalamus. So then from the thalamus, that is in the ventral posterolateral nucleus, it then goes to the somatosensory cortex. And similar or exactly the same as the dorsal column medial lemniscus system, this ascends from thalamus to cortex through the posterior limb of the internal capsule. And you will see internal capsule is the white matter branches, right? So here, modulation of substance of pain. Okay, so we had this at the substantia gelatinosa, and main two things to think about are, so we said we had a descending input from the spinomesencephalic pathways, and then this will mainly be endogenous opioids like endorphins and enkephalins. But another thing to think about is gate theory, which is about the theory that there's a mechanoreceptor fiber that basically can beat the C fiber from sending the pain information through an inhibitory neuron, but this has some controversy to it. So probably not an MCQ question, but if you want to write an essay, it's something that you would talk about. Okay, and we were saying these descending pathways, one of them being from the periaqueductal gray, and that's mainly controlled by serotonin and enkephalins. The locus coeruleus, that is with noradrenaline as a neurotransmitter, so it's like when levels of stress are increased, and the dorsal raphe nucleus, which is signaling through serotonin. So some of this has to do with why antidepressants can be helpful in treatment of neuropathic pain, maybe for the effect mood, but also maybe for the descending modulation of pain. Okay, so now we're done with the anterolateral system, and hopefully with the spinal cord lesions that we'll talk about, then we'll reinforce the neuroanatomy. So when thinking about spinal cord lesions, have to think about where is the lesion. To find that, can think about which level of the spine is affected, and then also about for that you can, if you know your reflexes in terms of which spinal levels are involved, that's important. And then, even though these are not really common injuries in real life, to have knocked out a certain modality, so say only knocked out pain or only knocked out proprioception, only knocked out touch, these are important to learn for the multiple choice questions because they come up quite often. So we'll go through them. But just before that, if you got any pen and paper or just in your mind, can you remember what spinal levels are for these reflexes? So biceps, triceps, knee and ankle. Give you a moment to think. And I can't see the chat if you're messaging, but just a moment. Biceps, triceps, knee and ankle. And I'll tell you an easy way to remember it. So how do we know this? It's based on the dermatomes that you probably will learn every so often when you have a neuro exam, but then you will kind of forget again and then relearn it. But a way that I think is that stuck for me is like a biceps is this. So it's 5, 6 pick up sticks. That is to pick up a stick. And then triceps, which is at the back, 7, 8, close the gate. And then the knee, if you kick your knee, that is L3, 4, kick the floor. And then the ankle S1, I think maybe I don't have a word for that, like a mnemonic. But another classic is C3, 4, 5, keep the diaphragm alive. So if you know there's an injury above 3, 4, or 5, then you can have respiratory failure because you're not having the innervation to the muscles of that help with breathing. Or the other one is S, 2, 3, 4, keep blank or pieces of the floor. Those are the ones for the important for the control of the anal sphincter. Right. So we said, are the arms involved? If they are, must be a list. So you got T1 on the side, then you've got C8 on the side of the finger, in the middle, C7, and then C6 with your thumb. And there's something called the dermatome shower. You can watch it on YouTube and can help to remember. And then when you're in the MCQ exam, everybody in the exam hall will be just going like that, remembering what are the dermatomes. Right. So this case, we've got a 65-year-old man who has come in because he burned both his hands on the stove while cooking dinner, but he only realized the injury later in the evening. but when you examine him, he can feel the touch to his hands, arms, and shoulders. So what's going on here? Clearly, this is something new because you would have realized if it was a congenital problem of not sensing pain from birth. So we know that he has lost pain and temperature sensation, but has now preserved touch and vibration sensation, because when you do the neuroexamination of only using, like, you're touching with his finger, he can feel that. So what do we think? If it's a spinal cord lesion, what system is affected? So we're thinking anterolateral system. So where could be that lesion? So in this case, it's quite rare, but there is cyst building in the middle of the spine that's called syringomyelia. So as we mentioned before, we have the first order neuron for anterolateral system, so nociception, synapses in the dorsal horn, and then very quickly after decussates to the other side to ascend contralaterally. So there's something that is stopping the information from going across that second order neuron. And this is in the anterior commissure of the spine. And so this cyst initially will knock out all of your nociception, but then as it grows bigger, it will also affect other modalities. But it's a case that they like to bring up in MCQ. That is, you will see a hood, like, well, depending on where the lesion is here, if it's in one of the C cervical spine levels, or then, well, if it is including T1 there, so it could be at T1 level, then it will only knock out the pain, but not the touch, because it's only knocked out anterolateral system, not dorsal columns, which are here at the back. Next case. So this time, this patient had a spinal cord lesion that is affecting at this level, and on the side of the injury has lost motor function and also mechanosensation, so touch, it's numb. And then contralaterally, though, has a loss of pain sensation. So what do you guys think? What could cause this? Yeah, exactly. Thank you, Megana. Right. Brown Séquard. And what is Brown Séquard? That's a name, like an eponym that means like a specific name for a disease like that somebody got because they discovered it. But the lesion is a hemisection of the spinal cord. That means you've knocked out half of the spinal cord. And it's called Brown Séquard syndrome. And why do we think that the loss of pain is at a lower level than the vibration proprioception fine touch? Any ideas? What could be the like anatomical basis of the, even though you have the lesion higher up, the pain is only, you got basically you've still got pain sensation at the same level, but it's a couple of levels down, then you don't have the pain sensation anymore. So it's a thing that we talked about was the Lissauer's tract, how that the first order neuron goes from the, say, from the skin to the dorsal horn, and in the doesn't go at the same level, it goes either up or down. So this could explain, even though you've got the lesion here, then it's not at the same level, because the neurons that you've got here, that you have injured here, they are coming from receptors from down here, whereas the receptors up here will go up Lissauer's tract and synapse in the spinal cord somewhere up here. Cool. So we had the hemisection as you've lost the half and half of the body, right? And of course, this is quite rare to see in real life to exactly get that, but common MCQ question because it demonstrates the neuroanatomy. Okay, and these are a couple of extras, probably less high yield, but maybe we'll just quickly mention them. You can also have a specific modality being lost, for example, in syphilis infection that is like long term that then infects the neurons, and then this particularly affects the proprioceptive neurons. So then you can imagine that could result in an abnormal gait. And this other one, in a lack of vitamin B12, you can get a subacute combined degeneration of the spinal cord. So when it says combined, basically has many different tracts are affected. So we have definitely a dorsal column, but it also has some corticospinal involvement, and that you will have a lecture for next week with the motor system. So corticospinal will be resulting in weakness, whereas you can imagine if you knock out the dorsal columns, you would get lack of the sensation in terms of touch, but also proprioception. Cool. So we have done now the spinal cord lesions, and we will move on to briefly cover cortical representation of somatosensory information. Okay, so we said the sensation in the brain, mainly the parietal cortex, and this is represented as a homunculus, which I'm sure you've come across. And a way to remember it is that you have the legs are hanging down into the middle of the brain, and then you have hands and face towards the outside. So that's how I usually think about it. Just the legs are hanging down in the middle, and then you got the rest. So hand and then face. And you can see hands and face are much bigger than legs and trunk. That's because you have more neurons for interpreting the location of the information. And important clinical relevance here goes back to neuroanatomy about what is the blood supply to the cortex. So you have the anterior and middle cerebral artery, both very important. Even the anterior cerebral artery is in the medial part of the brain. And so, like we said, the legs are hanging down in the middle. So if you knock out that part of the cortex, then it will affect the legs. And of course, will not only be some of the sensation, would also be some motor effects. That is for practice of learning. And then maybe annoyingly, the middle cerebral artery isn't in the middle. It's actually goes from the middle to then give blood supply to the sides of the brain. So mainly the like parietal lobe and here some of the frontal lobe. But if you remember, the anterior cerebral artery is the strip at the front, and then on the sides is the middle cerebral artery, which then we had arm, and then face. So if you have a lesion in, so for example, a ischemic stroke to the middle cerebral artery, then you will lose face and arm, and you might have heard a public health campaign of FAST. So for identifying a stroke, so there is face, arm, speech, and the time to call an ambulance. And then just for completeness, at the back of the brain, we got the posterior cerebral artery. That's mainly for the occipital lobe. Good, so we have finished our content for today. But if you guys have any questions, as I know we finished a bit early, feel free to ask. And I'm just gonna stop recording.